So today we will discuss about a very important topic of neurology, that is aphasia. So whenever we talk about the aphasia, we need to know about two very relevant terms. One is dysarthria and dysphonia. Dysarthria is basically, it is a disorder of articulation. That means there is a problem with the neuromuscular apparatus. Like we have spastic dysarthria, bulbar dysarthria, cerebellar dysarthria, and another term is dysphonia, in which there is a difficulty in phonation, there is a difficulty in production of vocal sounds. But this aphasia is very different from the other two. Aphasia, or what we call as dysphasia, it is basically a deficit in formal aspects of language. It is a disorder of structure and organization of language, or deficit in formal aspects of language. Now, what are those formal aspects? It includes the word finding, the word choice, the grammar, the spelling, and of course the comprehension. These are the formal aspects of language. So the deficit in them is included in the category of aphasia. Now let me talk about the language network. In 90% of right-handers and in 60% of left-handers, this aphasia results if there is a lesion in the left cerebellar hemisphere. Okay, so left hemisphere is the predominant hemisphere involved in language disorders. So we'll talk about the language network. So an important term here we will talk about is the language network. So language network, it is classically located in the perisylvian area in the left hemisphere. So if I look at the cerebral hemispheres, so supposingly this is left hemisphere, so the language network is located in the perisylvian area in the left hemisphere. Here there is a Wernicke's area in the superior temporal gyrus. Here there is a Broca's area in the inferior frontal gyrus, and the connecting fibers which are known as the arcuate fasciculus. So language network is classically located in the perisylvian area. So if there is an infarct or a hemorrhage or a neoplasm in this area, so that will result in aphasic syndromes. Now we'll move on to each one of the aphasic syndromes, but before that we'll discuss an important thing, that is the clinical examination of language. So when we talk about the clinical examination of language, so what does it include? So when we examine the language function, so it is, these are its components. First we'll look at the naming. I'll just write down first of all naming, comprehension, fluency or spontaneous speech, repetition, reading and writing. So सबसे पहले हम बात करेंगे नेमिंग के बारे में. So the deficit of naming is known as anomia, and anomia is the single most common finding in aphasic patients. So the deficit of naming is called as anomia. So what does it mean? मान लो, if I show, supposingly I show a patient a pen, okay, and I ask him to name it, so he may come up with a circumlocuous description of this object. वो कह सकता है कि भाई it is something to write, it is a thing for writing. So he is not able to name it, he gives you a description of this object, or he may come up with the wrong words, which is called as paraphasia. So what could be the possibility? The patient can come up with a circumlocution description. You can come up with a circumlocution description of object, or he may come up with the wrong words, which is called as paraphasia. Now this paraphasia are again of two types. One is semantic paraphasia, another is phonemic paraphasia. Semantic paraphasia means कि मान लो वो पेंसिल की बजाय बोल रहा है पेन, मतलब he is telling you a incorrect but related word. Okay, so that is called as semantic paraphasia. मतलब the word is related but it is incorrect. And phonemic paraphasia means पेंसिल के लिए वो बोल रहा है प्लेंटिल, मतलब he is approximating the correct answer but phonetically it is incorrect. So that is phonemic paraphasia, and semantic paraphasia is saying pen for pencil. So the example here is, supposedly I ask him to name pencil. So if you say it as a pen, so that is a semantic paraphasia. And if you say it as a plantil, so that is a phonemic paraphasia. And if he says that it is something, it is a thing for writing, so that is called as the circumlocution description of object. So this is all included in under the umbrella of anomia. Okay. Now coming on to the another important part, that is comprehension. Comprehension matlab samajhna. So comprehension could be for two things, for the written language and for the spoken language, right? So we have to assess the comprehension for spoken language and written language. So this Wernicke's area is classically the site for comprehension. So this Wernicke's Broadman area number 22, it is the site for comprehension. Comprehension is severely impaired in patients with Wernicke's aphasia. While Broca's, it is the area for spontaneous speech. So what is included in under the this category of spontaneous speech is you have to assess the fluency of the patient. So we categorize it as fluent or non-fluent aphasia. Fluent means there is adequate volume output, there is adequate volume, there is adequate phrase length, there is adequate melody. And non-fluent means ruk ke, sparse, halting, very labored speech. Okay, and average phrase length is less than 4 words. So that is called as non-fluent. So when we talk about the spontaneous speech, so what is included is, one is fluency, and apart from that we also assess the grammar, the tenses, the prefixes, suffixes, plurals, possessives. So the word order, which is called as syntax, all of that is included in the grammar part. So in spontaneous speech, we look at the fluency, which is very important because we can broadly classify the aphasia into fluent aphasia and non-fluent aphasia depending upon the fluency. And grammar is also included in the spontaneous speech. Now looking at the repetition part, repetition we ask the repetition we ask some 1-2 word to the patient to repeat, or you can ask for the simple sentences also to repeat, or you can ask like no, ifs, ands, buts, right? So you can ask him to idhar, udhar, right? So like short words you ask him to repeat and then assess. So repetition is basically a function of these conducting fibers which conducts the Wernicke's and Broca's areas, which is also called as arcuate fasciculus. So if there is a disconnection between these two areas, or this arcuate fasciculus is injured, so repetition is severely impaired, right? And coming on to the, and how do you assess for the comprehension? Comprehension के लिए you ask him simple yes no question, right? क्या कुत्ते उड़ते हैं, right? क्या गर्मियों में ये बर्फ गिरती है, such type of question. Or you can ask him कि इस रूम में लाइट कहाँ से आ रही है, या इस रूम की एंट्रेंस कहाँ से है. So you can ask simple yes no question, or simple the pointing out object, like such type of question you can ask the patient. And spontaneous speech में you have to assess for the fluency and grammar that I have told you, right? Naming के लिए you show him some objects and ask him to name it. And reading and writing, they are also an important part. So when we talk about the reading, so reading you have to look for two things. One is ability to read aloud. Another thing is comprehension of written statements and written words. So two things are looked for in a patient of reading. One is ability to read aloud, and another thing is comprehension of whatsoever he is reading. So the comprehension of written words and statements. So alexia is a word which is used for deficit in reading. So even if there is a patient is having difficulty in reading aloud, that is considered as alexia. Also, if a patient is having merely difficulty in comprehending the written statement, so that is also included in the alexia. And last part is writing. Okay, so these are the components of the clinical examination of language. Now I'll move on to discuss the aphasic syndromes one by one. So now we'll talk about the Wernicke's aphasia. So first of all, you need to know about where is this Wernicke's area actually located. So here I am trying to show that this is the superior temporal gyrus. The Wernicke's area is located here in the superior temporal gyrus, and it is being supplied by the inferior division of the middle cerebral artery. It is the main stem, superior division, and the inferior division of the middle cerebral artery. So if there is an embolic occlusion of the inferior division of the middle cerebral artery, so that is the most common etiology of Wernicke's aphasia. Apart from that, if there is a hemorrhage in this area, or if there is a tumor in this area, or there is a head trauma, so they are the other causes of Wernicke's aphasia. Now, what would be the consequences of Wernicke's aphasia that we will see? Look at this example. Here a patient is trying to say that his wife threw away something important, perhaps his dentures. So look at the way he's saying it. We don't need it anymore, she says, and with it when that was downstairs was my teeth tick, A, dentith, my dentist, and they happen to be in that bag, C, where my two little pieces of dentist that I used, that I all gone. If she throws the whole thing away, visit some friends of hers and she cannot throw them away. So what do we infer from here? हमें यहाँ से क्या पता चलता है कि there is a voluminous, it is too voluminous but uninformative. So the correct thing to say here is it is too voluminous but uninformative. There are very few substantiative nouns in this. So this is what happens in a patient of Wernicke's aphasia. We'll try to look at each of the components. Most severely affected is the comprehension. Okay, so comprehension, fluency, speech, repetition, naming, reading and writing, coexisting neurological deficits, and personality. So we'll discuss under these headings that what happens actually in a patient of Wernicke's aphasia. So I've told you that comprehension is severely impaired. Patient is not able to understand the written or the spoken language. So much so that he is not able to understand what he is speaking. He lacks insight. उसको ये भी नहीं पता होता कि वो खुद क्या बोल रहा है, right? So he talks anything nonsense, right? Now if I talk about the fluency, so fluency is preserved, rather it may be also increased, right? So fluency is preserved. Now how is the speech of this patient? So the speech is circumlocuous, highly paraphasic, neologistic, jargon aphasia. So I have used these heavy words. Already I have explained about few to you. Circumlocuous means if you show him some object and you ask him to कि ये क्या है, so he will not come up with the right word, but he will describe you the use of this object, right? Or paraphasic means he may come up with the wrong words which may be semantically wrong or which may be phonetically wrong, right? तो paraphasic मतलब वो गलत words use करेगा. Circumlocuous मतलब he is not able to name but वो उसका description देगा, right? Neologistic matlab new words. Okay, you will come up with the new words, right? I have eaten rice and Abu Dhabi Gabi in the morning. Now this Abu Dhabi Gabi holds no meaning in dictionary. So he evolves new words. So a string of new words that is called as jargon aphasia. So this is the classical speech, also neurolinguistic also consider it as paragrammatism. So this is circumlocucious paraphasic neologistic jargon aphasia. Neologistic means new words, evolve new words which holds no meaning to it. And how is the repetition? Because you do not understand what you have said, so repetition is definitely impaired. And what about the naming? If you show him something, so again naming will be impaired. Either he will give you a circumlocucious explanation or he may give you wrong words, right? So again it is impaired. Reading and writing both are impaired because patient is not understanding the written things and also the spoken things, right? In writing also is writing anything, okay, because it lacks the insight. He don't know about the problem he is having. Now, what could be the coexisting deficits? A few days back, I've discussed with you that here runs the optic radiation. So if there occurs the infarction of the sensory area, so usually right hemianopia is coexisting with it. Because I've told you that in majority of time it is the left hemisphere which results in aphasic syndrome. So if the left optic radiation is affected, so it results in right hemianopia. Now how is the personality? Because these patients lack insight, so they are saying anything, okay, nuisance, and the person sitting in front, he is not understanding. उसको समझ नहीं आ रहा है कि वो आदमी क्या बोलना चाह रहा है. So these patients easily lose their patience. They are impatient, they are very angry, क्योंकि उनको लगता है कि कोई उनकी बात का जवाब क्यों नहीं दे रहा है या उनकी बात को समझ क्यों नहीं रहा है. उनको नहीं पता कि what problem they are having, right? So these patients are usually impatient and angry. They lack insight. अब यहाँ पे एक दो चीजें मैं और बताना चाहूंगा कि if you show him the gestures, so does it improve the communication? No. Gestures, अगर आप gestures से समझाने की उनको कुछ कोशिश करो, so gestures, pantomime करके आप माइम करके कुछ उनको समझाने की कोशिश करो, that also is not helpful, right? So that does not improve the communication. And एक important चीज जो है, someone out of you may ask कि how will you distinguish it from deafness? कि मे बी उस आदमी को वो बहरा हो, उसको सुनाई ना देता हो, तो उसको नहीं पता लगेगा कि हम क्या पूछ रहे हैं. रेपिटेशन विल बी इम्पेयर्ड, नेमिंग रेपिटेशन विल बी इम्पेयर्ड, राइट? सो हाउ विल यू डिस्टिंग्विश इट फ्रॉम डेफनेस, और हाउ विल यू डिफरेंशिएट इट फ्रॉम अ साइकाट्रिक डिसऑर्डर और मेलिंगरिंग? सो वेरी इंपॉर्टेंट थिंग, एंड अ पेशेंट ऑफ वर्निके अफेजिया, आप उसको पूछोगे व्हाट इज योर नेम, तो वो उसको नहीं बता पाएगा. लेकिन आप उसको बोलोगे अपनी आंखें बंद कर, राइट, या उठ के बैठ जा, या फिर बेड पे रोल कर. So the motor commands which are aimed at axial musculature, that is preserved. He is able to follow the motor commands which is aiming at axial musculature. So this dissociation between inability to understand simple sentences and the follow commands which are aimed at axial musculature is classical of Wernicke's aphasia, and it distinguishes it from deafness, from malingering, from psychiatric disorder. So this is all about the Wernicke's aphasia, and the prognosis is guarded. Okay. So look at this example once again. Again, you are not able to infer anything out of it. It is too voluminous. Fluency is preserved in this, but patient is also not perhaps understanding what he is saying, right? So this is the typical example of Wernicke's aphasia. Now we'll move on to Broca's aphasia. Now we'll talk about the Broca's aphasia, which is another important aphasia, which is called as motor aphasia. So when we have discussed about the Wernicke's aphasia, so if I ask you a question that whether it is an expressive aphasia or it is a receptive aphasia, so yes, I know majority of you will say that it is a receptive aphasia, and it's true partly. It has both components. It is a receptive as well as an expressive aphasia. Receptive in the sense that patient is not able to understand written or spoken language, and expressive in the sense that patient is not able to express his thoughts in meaningful words and sentences. So it has both components to it, expressive as well as receptive components. So if asked in an MCQ, so you can say that it has both components. Now coming on to a Broca's aphasia, first of all we need to know about that where exactly is this Broca's area located. Broca's area is located in the inferior frontal gyrus. जब हमने Wernicke's area की बात की थी तो that was located in the superior temporal gyrus, Brodmann area number 22. And जब हम Broca's की बात करते हैं तो inferior frontal gyrus में होता है, इसका Brodmann area number 44 and 45 होती है. Pars opercularis and pars triangularis also it is called as. Now how it is different from Wernicke's? Wernicke's को कौन supply करता था? Inferior division of middle cerebral artery, and it is being supplied by the superior division of middle cerebral artery. So again, if there is an infarction due to occlusion of superior division of this middle cerebral artery, so that is the most common cause. Apart from that, hemorrhage, tumor, okay, so these can be the other causes of it. Now coming on to the different components. Before that, I want you to look at this example. Here a patient is describing his medical history. He says, I see the doctor sent me boson, go to hospital, doctor kept me beside 2-3 days, doctor sent me home. So look at this paragraph. Here there are very few words, but it is informative. It is very telegraphic type of, very concise type of speech, okay? But it is informative. There are too many nouns in it. So this is how it is different from Wernicke's aphasia. Wernicke's there is voluminous output, but is uninformative. Here there are very few words. It is very concise. It is telegraphic, very hesitant, labored speech, but it is at the same time informative. So looking at the fluency, so fluency is definitely decreased. So it is also called as non-fluent aphasia. और Wernicke's को क्या बोलते हैं? Fluent aphasia. यहाँ पे fluency decrease हो जाती है. Patient की speech जो होती है वो बहुत ज़्यादा labored होती है, बहुत ही hesitant होती है. Okay? Patient को बहुत force लगाना पड़ता है बोलने के लिए, right? So there is very labored, hesitant speech, and it is interrupted by many word finding pauses, right? उसको word finding pauses होते हैं इसमें बहुत ज़्यादा, right? So it is interrupted by word finding pauses. As you can see in this example also, he is trying to find the word doctor, right? And one important thing which is very important in Broca's this aphasia is grammar. There is agrammatism, right? Patient कोई भी grammar का बहुत कम use करता है, right? तो जैसे patient बोलेगा wife come hospital, right? That his wife has come to hospital, to visit hospital or whatsoever. So he used very few words. So there is agrammatism. So agrammatism is a hallmark feature of this. So if somebody asks you which aphasia is agrammatic aphasia, so that is Broca's aphasia, agrammatism. Particularly जो word order होता है, word का एक के बाद दूसरा वर्ड आएगा which is called as syntax और word order, वो इसमें impaired होता है. एंड साथ में बाउंड मॉर्फेनिम्स. बाउंड मॉर्फेनिम्स होते हैं जैसे कुछ वर्ड के आगे हम प्री लगाते हैं, जैसे प्री टेस्ट प्रोबेबिलिटी, या डिस लगाते हैं, डिसकंसेंट, डिसेंट, या फिर अन, है ना, अन लगाते हैं, ठीक है, या इन लगाते हैं, इनएबिलिटी लगाते हैं, ठीक है, या फिर जैसे कुछ वर्ड्स के लास्ट में लगाते हैं जैसे ऑर्डरली लगाते हैं. सो ऑल ऑफ दीज आर कॉल्ड एज बाउंड मॉर्फोनिम्स. इसका पर्टिकुलरली पेशेंट यूज नहीं करता है. सो दैट रिजल्ट इन एग्रामेटिज्म, राइट? What about the comprehension? Comprehension is preserved. This is the major difference. In Wernicke's aphasia, comprehension is impaired, but here comprehension is preserved, but fluency is decreased, right? It is preserved. यहाँ पे भी एक कैच है कि जब अगर हम पेशेंट को कोई बहुत कॉम्प्लेक्स स्टेटमेंट बोलते हैं जिसमें बहुत सारे एम्बेडेड क्लॉजेस होते हैं, जैसे मैं बोलता हूँ कि मान लो कि राधा ने राम को जो गलीचा गिफ्ट किया था वो कोई चोर लेके भाग गया. सो इफ देयर इज अ कॉम्प्लेक्स स्टेटमेंट जिसमें बहुत सारे क्लॉजेस एम्बेडेड हैं तो उसको समझने में पेशेंट को डिफिकल्टी होती है. तो अगेन इट हैज बोथ एक्सप्रेसिव एज वेल एज रिसेप्टिव कंपोनेंट, राइट। तो रिसेप्शन में भी इसको प्रॉब्लम होती है, पर्टिकुलरली जो सिनेटिकली बहुत कॉम्प्लेक्स स्टेटमेंट्स होती है ना, ग्रामेटिकली बहुत कॉम्प्लेक्स स्टेटमेंट्स होती हैं, उनको अंडरस्टैंड करने में डिफिकल्टी होती है, राइट। रेपिटेशन क्या होता है कि इट इज समझ आ रहा है उसको, जैसे आपने बोला कि बोलो वाटर कूलर, तो उसको समझ आ गया कि बोलना है, वो कंडक्ट भी यहाँ पर हो गया आर्क्योइड फेसिकुलर से, लेकिन बोलने में अगेन देयर विल बी डिफिकल्टी, राइट। सो इट इज समहाउ impaired because he is not able to express it properly. So is the case with naming also. And surprisingly reading and writing is also impaired. That is out of the context, but if I discuss here, so reading में इसको बोलते हैं थर्ड अलेक्सिया, कि अगेन जब पेशेंट रीड करेगा तो उसको वर्ड ऑर्डर का नहीं पता चलता है, उसमें सिंटैक्स इज वेरी क्लासिकली डिसरप्टेड इन अ पेशेंट ऑफ ब्रोकास अफेजिया, तो उसको वर्ड ऑर्डर का नहीं पता चलता है कि पहले किस तरह से बोलना है। तो रीडिंग इज ऑल्सो इम्पेयर्ड विच इज कॉल्ड एज थर्ड अलेक्सिया। एंड राइटिंग में क्या होता है, डिसग्रामेटिकल, अगेन जब वो लिखता है तो बड़ा ग्रामर बिल्कुल उसका खराब होता है उसमें। अपार्ट फ्रॉम दैट डिसमॉर्फिक, अब आई टेल यू व्हाई डिसमॉर्फिक। So this is dysmorphic and dysgrammatical. देखो एक रीजन तो ये है कि Broca's aphasia is in very close proximity to the primary motor cortex. You can see here, this is primary motor cortex, this is central gyrus, this is precentral area is the this is precentral gyrus is the primary motor cortex, ठीक है। तो it is close proximity to Broca's area. तो there is usually associated hemiparesis, है ना, हेमीपैरेसिस होता है, या फेशियल वीकनेस होती है सबसे नीचे यहाँ पे, तो फेशियल वीकनेस हो सकती है, या फिर क्लासिकली होता है बक्कोफेरेंजियल अप्रेक्सिया। नाउ व्हाट इज दिस बक्कोफेरेंजियल अप्रेक्सिया? बक्कोफेरेंजियल अप्रेक्सिया मैंने पहले भी बताया, अप्रेक्सिया इज इनएबिलिटी टू फॉलो learned inability to perform learned activities despite normal power and coordination. तो अगर आप पेशेंट को कोई this buccopharyngeal, bucco means this oropharyngeal और facial muscles, पेशेंट इज इनएबिलिटी टू फॉलो कमांड्स जिनमें इनकी इन्वॉल्वमेंट होती है, जैसे आप पेशेंट को बोलो कि सक straw or blow out a matchstick, so he is not able to do that. So these are usually associated with it, क्योंकि हेमीपैरेसिस साथ में एसोसिएटेड होता है, तो उसको राइट हैंड से वो लिख नहीं सकता, क्योंकि लेफ्ट हेमिस्फीयर में दिक्कत होगी, राइट हैंड से लिख नहीं सकता। तो लेफ्ट से जब वो लिखेगा तो इट इज मोर इम्पेयर्ड दैन अ नॉर्मल पर्सन। जैसे नॉर्मल पर्सन भी जब लेफ्ट हैंड से लिखता है, फिर राइट हैंडेड पर्सन राइट विद द लेफ्ट हैंड, तो वो थोड़ा गड़बड़ सा होता है। बट इन पेशेंट ऑफ दिस ब्रोकास अफेजिया इट इज फर्दर वर्स देन दैट। So this is dysmorphic and dysgrammatical. And what about the personality? Important thing is Wernicke's aphasia, if I talk about the insight, that is absent. उनका insight lost हो जाता है, उनको नहीं पता होता है कि what they are suffering from or how what is the actual problem with their speech, right? But यहाँ पे पेशेंट को पता होता है कि मुझे बोलने में दिक्कत है ना, I am not that conversant. So here the patient is tearful, they are depressed. Okay, यहाँ पे पेशेंट को डिप्रेशन ज्यादा कॉमन होता है, वहां पे पेशेंट को एजिटेशन, राइट, impatient attitude, angry, that is very common. Here on the contrary, patient is more commonly depressed, but it has a better prognosis than Wernicke's aphasia. यहाँ पे speech therapy ज्यादा helpful होती है in contrast to Wernicke's aphasia. So this is all about the Broca's aphasia. I hope everything is clear. Just look at this example and try to understand what I have told you, that fluency is definitely decreased. If you give a patient a time of say in 1 minute and you compare a patient of Wernicke's and Broca's, तो 1 minute में वो अगर 100 words बोलेगा तो ये 20 words बोल पाएगा. So fluency is decreased, right? And speech, it is very labored, it is very hesitant, interrupted by word finding pauses, right? Comprehension में क्या होता है? Agrammatism is very important. I'll just underline also that is an important part of Broca's aphasia. Comprehension, it is preserved, right? And but there is a impairment in understanding the grammatically complex statement. So yes, it also have a receptive component. Apart from expressive component, it also have a receptive component. So again, if asked in MCQs that what kind of aphasia it is, so it has both expressive as well as receptive components. Now repetition is impaired, naming is impaired, reading, writing, they are also impaired. Associated deficits could be hemiparesis, facial weakness, or buccopharyngeal apraxia. And personality, they are depressed, they are tearful. Okay, so that all I have to tell you about the Broca's aphasia. I'll discuss the rest of aphasias in my subsequent lecture. Thank you very much.